All right, folks, welcome back. We're ready to start the next session of our webinar today. We'd like to welcome Emopti. Emopti is a pioneer in teletriage technology that allows healthcare providers to conduct video consults with patients across the emergency room. This teletriage platform is particularly targeted to ED physicians to triage their patients remotely, which helps EDs manage their patient surges, obviously reduces provider exposure to contagious patients, and allows quarantine clinicians to productively and safely continue to facilitate patient care. Redox and Emopti have worked together for many years, well before the COVID pandemic. We're really excited that Emopti is joining the COVID-19 response. They have a fantastic solution, and we'd like to welcome Dr. Ed Barthel, CEO and founder of Emopti. Ed, take it away.
Thanks, Devin. I appreciate it. So the audience is hearing from two emergency physicians in a row. This is a very kind of personal time for us because we've got colleagues that have been out there trying to take care of patients and gotten sick themselves, and now they're in ICUs on ventilators. And we wish them the best and want to do anything we can to help the industry. As Devin mentioned, we've been around for several years, working to help improve patient flow in busy acute care environments. Now it's this unique time where emergency departments all over the country are putting up tents out front, trying to divert patients from even having to enter their facilities, trying to come up with ways to decrease exposure of both patients and providers in new ways. So folks all over are scrambling to come up with telehealth solutions and virtual means for communicating with patients. It's kind of sad when I have to see that people are trying to scramble and use tools that were created for business conference calls or created for consumer visits for these very busy environments in emergency department facilities or out in their parking lots even. And that's exactly what Emopti was built for, is to work in these kind of complex environments. So folks tend to think of telehealth as maybe one big bucket, and in reality is there's many, many different types of telehealth solutions. The ones that are probably the best known are a number of companies that provide business to consumer type visits at the home, very valuable to help patients that perhaps have fevers or cough and are wondering, do they need to even go to an emergency department? Gives them a way to get a healthcare provider to give them some advice. I think that's tremendously valuable. It's just not where we've focused. Similarly, in emergency departments, there's been use of telehealth that tends to be kind of once in a while for very special situations, with the classic example being consulting a neurologist when you have a stroke patient. We're different from that as well. We've really tried to design our software to support high volume, system-wide patient flow at very high speeds, where every click matters. So the premise is that instead of having a care process that always involves on-site staff, let's break down the care process into components or parts of work, and some of those components can actually be done by remote resources, and very often can be done faster, better, cheaper by those remote resources. And particularly when you're looking across a group of hospitals, you can have a remote resource servicing multiple hospitals simultaneously, which gives you a load leveling effect between those hospitals that you just can't do when you're only using individual providers at individual sites. At the front end, at the virtual intake process, that's where we've had the most experience over the last several years. And people are now trying to redesign those workflows in ways that they can keep patients out of the ER that don't need to be in the ER. And so, as I said, tents are going up in parking lots outside of emergency department entrances all over the country. We take this approach is to take, instead of $25,000 telehealth carts, we use very inexpensive tablets that are mounted in a variety of different brackets or on mobile poles that can be moved to multiple locations. These are $1,500 a piece instead of $25,000 a piece. It's off-the-shelf hardware that can be ultimately put in many different patient rooms at the same time, and you can have several of these units out in the tent. And every time you're using a person on a screen like this in a tent, that's one less person that has to be in that tent and exposed to someone that's potentially infectious. At the same time, we connect that through, and this is where our Redox comes in, is we take a ADT and vital sign feeds out of the electronic medical records. So the carts on the right maybe are being used by a nurse or a tech in the tent to enter the patient into their electronic medical record and get them registered and do some documentation. At the same time, the ability to request a remote consult to one of these patient-facing devices is integrated directly into the screen with the electronic medical record. So then when those consult requests are made, they can go out through a routing and queuing system to one or many different responding facility or responding centers. And frankly, in this age where we have quarantine providers, we can set this up in providers' homes as well. And so you can have multiple different responders working from multiple locations and working together, so that there's a broadcast type event that can go to multiple different locations, and you essentially are crowdsourcing your responses, or you can have directed consult requests to certain types of people. So that can occur based on attributes of the patient or attributes of the requesting facility or attributes of the responders. If I'm one of the triage nurses or one of the techs out in the tent, I'm going to do vital signs and get the patient entered into, in this case, it's an Epic electronic medical record, but we can operate with others as well. And all we do is steal some of the screen real estate on the left side of the screen there, where we put our software runs in parallel with the EMR, but it's on the same screen. So all the nurse has to do is slide the mouse over and go click request consult. And if it's requesting a triage consult, within 30 to 60 seconds, the doc on the other end is going to pop onto the screen. Now, if I'm a doc in the responding area or command center, we sometimes call it, I have a queue, and you'll see that on the far left, of incoming consult requests, and that consolidates those requests from multiple different providers or multiple different facilities and stacks them up with sorting mechanisms that we configure. Typically, it's based on whenever the last consult request came on, and I'm going to grab the patient off the top that's been waiting the longest, go click, and all of a sudden now I can see that patient right on my screen. Have an assessment occur where I decide what tests need to be done. For some of the worried well, I can answer questions and just get them those patients discharged out to home, and they never have to go into the facility. And if orders are needed, I can then enter those directly into the electronic medical record, which is in another screen just adjacent. If you go back here, you'll see, for instance, on the picture in the upper right, he's got our screen in the top middle, and then he has his electronic medical record for entering orders or documentation directly underneath that. So because of COVID, we've tried to repackage our software into a rapid deployment type of a package so that we can install it within 7 days and have it deployed in multiple emergency departments and multiple different responding command centers involving multiple different providers, all orchestrated together. There's no software fees over the next 90 days and no long-term obligations. We've proven the deployment can work. We had a hospital system in Tampa just say go last Tuesday, and they are now today live in patient care with this system. So it's really ready to go now when we have such an urgent need. No expensive carts or hardware needed. You can do the queuing and routing. It's super fast. In general, it's about 3 times faster than most alternatives. And we've got a proven capability that was used way before COVID. This has not just been created for the COVID pandemic. We've already logged over 300,000 virtual consults across our customer base.